Coming to the close. Whoa, there we go. So here we are coming to the close of the energy module, and we're very excited about this segment. We as faculty are very passionate about certain subjects, and we recognize that they have an incredible importance, and this is going to be a lot of fun. I do want to let you know that we switched up the order of things a little bit. So in your slide decks, in your PDF, it's not going to go directly in the same order. So just, shift which speaker you're seeing. The slides are all the same, but just a slightly different order. And as we proceed forward, we're going to be again taking questions. There's a Facebook group that will be occurring. We're going to be having 2 separate webinars. They're going to be answering questions in a recorded format. So for both of you back there in live stream, and thank you for sending in your photos. Thank you for participating on the Facebook page. It's just been awesome. Just so great. We feel you all. Just wish we could have some holograms going of hula hoops on the side, right? So without further ado, I'm going to introduce to you the one, the only, Dave Reichel. Come on up, brother.
Thanks for being our guide, our energy giver. He just raises my testosterone just being around him. You tell the hormone people it's his energy that raised my testosterone, not just taking the... All right. As one of my side jobs, I am the editor-in-chief for Primary Care Practice Update, where we review the literature weekly, and we call ourselves the pancreas for the clinician, where we digest the research and then put it in easy-to-understand terms for people to apply in their practice right away. So I just pulled out of the literature over the last couple of years some key nutritional pearls, if you will, that I thought have changed my practice a lot, and hopefully they will give you some insight as well. First one, what ingredient may be the next artificial health risk? Now, a nutritionist told me a quote. She said, this is back when margarine was popular. She said, I choose to eat butter because I trust cows more than biochemists. And if you think about how we have tried to manipulate nutrition, every time it has failed miserably. Margarine, trans fatty acids, high fructose corn syrup. And what do you think's the next one? I'm predicting it's going to be the big next one. That is non-nutritive sweeteners. Non-nutritive sweeteners are pretty much infiltrating all of our foods. This is a study looking at those who drank more than 1 soda a day with artificial sweeteners. They did not see this effect when the soda just had sugar. It was only with the artificial sweetener that they saw much higher risk of stroke. And one of those, aspartame, when it gets metabolized, one of its metabolites is formaldehyde, which breaks up the blood-brain barrier. What did Bob call it? What'd you call it? The psycho... Thank you. Yeah, this may add to that. Is some of these non-nutritive sweeteners may be disrupting the blood-brain barrier, increasing the risk of stroke, as well as cognitive impairment and memory loss. So if you think about how much these are being consumed in our populations, this is a concern. Now, this kind of goes out of our paradigm. We were talking yesterday about our conditioned mind. If I asked you which causes more weight gain, a zero-calorie water or a zero-calorie diet soda with non-nutritive sweetener, which one would you say? They both have 0 calories. Actually, you know the answer. It's the non-nutritive sweetener. Actually increases weight and creates a metabolic dysfunction. So why is that? They both have 0 calories. Well, it comes to be known that each of our cells along our GI tract has a sweetness receptor on it. And what happens when we stimulate sweetness? The body stimulates insulin release. And insulin promotes inflammation in the body, particularly when it's not needed. These non-nutritive sweeteners are being put in energy drinks. It's probably the worst thing you could put in an energy drink. It's something that's going to stimulate the sweetness receptor, but not give you sugar to give you energy. It's actually going to cause you to become hypoglycemic. There's a new sweetener called Avantame that's 20,000 times sweeter than sugar. This overstimulation of these sweetness receptors, I believe, this is just the beginning of the iceberg of how this might influence health in regards to overutilizing some of these things that biochemists, initially with really good intentions, but generally when we try and manipulate nature, it doesn't always end well. Second question. Now this is for general health for every human being, looking mainly at cardiovascular disease, because that's what most of us are going to die from. Some cardiovascular disease. This is not neurodegenerative disease. Actually, the research shows that we need some fats, as Dr. Wall said, to remyelinate our nerves. Statins are not the best drug if you have MS or if you have Parkinson's disease, because you actually need some of that cholesterol to remyelinate the nerves. This research is mainly for everybody to facilitate health long-term, mainly in relation to cardiovascular disease. And this slide kind of hints at where we're going. Heart attacks, God's revenge for eating his or her animal friends. And if you look at study after study, there's been so many studies showing this to be the case. I ran out of room to list them here at the bottom. And it's really pretty simple. You all know this well. If we can get most of our protein from roots, such as beans and nuts, then fins, then 2 legs, then 4 legs, that's probably the best way to go. The 3 most inflammatory food groups are red and processed meat, sugar, and dairy. So let's talk about sugar. That pendulum kind of swung from fat is bad. So, and you all know this, fat was bad, so what did we eat more of? We ate more sugar. And the Pure study across 18 countries showed that sugar intake was the main cause of cardiovascular mortality, more than any other food nutrient. So I think, for some reason, particularly in America, we have a hard time just being in the middle. We always have an opportunity to go to the extremes. Now, some of the unhealthiest diets I have seen have been in vegetarians, because they start to eat a lot of carbs, a lot of sugar, a lot of things made from bleached white flour, where we take the sugar and remove all the fiber, and that's more or less sugar. So any white food. It's also the most important therapy we have for elevated triglycerides. That's a fat of sugar. It's not a fat of cholesterol. It's not a fat of saturated fat. This study looked at people who didn't eat red meat, but they ate a lot of processed white foods, and their risk of coronary artery disease was actually greater than those who just ate mainly animal protein. But the best was a high fiber plant-based diet, those 8 to 9 servings of vegetables that Dr. Wall encouraged us all to eat. All right, so there was 2 main studies that kind of were published back-to-back in 2018. This is a study looking at the highest score of the Mediterranean diet. So if you eat the ideal Mediterranean diet, you get a score of 9 points. And if you look at the very last ingredient, it's little to no red or processed meat. So they took people with the highest score of the Mediterranean diet versus the lowest score of the Mediterranean diet and looked at their cardiovascular risk of a major acute cardiac event, which was 28% reduced in those who had a high score of the Mediterranean diet. The next study, so why is that? Is it the red meat? Is it the inflammatory potential? Hard to say. The next study then compared a vegetarian diet to the American Heart Association diet. The only difference between the vegetarian and the American Heart Association diet was meat, red meat. And then they looked at C-reactive protein, and those on the vegetarian diet had a 32% lower C-reactive protein compared to the American Heart Association diet. And then they looked at the main risk factors for cardiovascular health, and they found out that inflammation was the top. That was the highest risk for having a cardiovascular event. So it's also Meatless Mondays. Have you heard about that? It takes 20 calories to create 1 calorie from meat. And what's that doing to the carbon footprint of our planet? So one of the most beneficial things we can do for the health of our planet is eat less meat. I'm not supported by the meat industry. Now, what also feeds TMAO? TMAO is created when we eat cheese and meat, which are high sources of phosphatidylcholine, carnitine, and betaine, that then combines with your microbiome, makes trimethylamine, and then there's an enzyme in the liver called flavin monooxygenase that the pharmaceutical industry is actively trying to find a drug to inhibit, which would reduce TMAO, which has been found to increase platelet aggregation and atherosclerotic tightening, stiffness, and in this study was blamed for 63% increase in death from all causes. So it's just like statins. We could bring down our LDL cholesterol by eating better, or you could take the statin. When this drug comes out, we could lower TMAO by eating less of these foods that are rich in these chemicals that are needed to create this potential harmful chemical. All right, next question. What supplement is the least expensive and most beneficial to treating metabolic disease? In my population that's very poor, who can't afford a lot of medications, I prescribe this to pretty much everybody because it does everything well. Soluble fiber slows the glycemic index of the meal if I use it before a meal. It slows the cholesterol absorption of the meal if I use it before a meal. It soaks up water, which makes me feel less hungry, results in weight loss. Fiber stimulates the mucus, which is the home for our microbiome, and this is pennies a day. Do you know how much a drug needs to reduce hemoglobin A1C to be approved by the FDA? 1/3 of a point, 0.3. Using 1 tablespoon of a soluble fiber such as psyllium before each meal 3 times a day equals about 13 grams, which will lower your hemoglobin A1C by almost 2/3, or 0.6. I was promoting that probably more than I should. 0.6 is what this was found to be beneficial for. Or you could just eat a bunch of vegetables, right? Because you'll get that much fiber just by eating the fiber-rich foods. All right, which supplement may be the baby boomer's best friend? This research has just come out in this last year. What do most baby boomers have a risk for? Achy knees, arthritis, as well as most of us will die from heart disease. Glucosamine. Glucosamine increases the fluid content in the cartilage. Chondroitin increases the synovial viscosity, the egg yolk substance of the synovium. Those glucosamine in the MOVES trial, compared to Celebrex, work just about as well for both pain and function. But what came out this last year was those Brits, and I met a couple Brits here from London in the room. This is a study of 466,000 Brits who were taking glucosamine versus those who were not. And then they looked at their incidence of coronary vascular events, and there was over 7 years, which was pretty impressive, and there was a 15% reduction in cardiovascular events with the glucosamine. The VITAL study also supported this finding, and that showed a reduction of almost 18% cardiovascular risk. All right, you may not like this one, but it's what the science is teaching us. Does taking a bunch of supplements for prevention work? Now let's preface this. This isn't for a bad eating college student. This is for someone who's eating fairly well. Does adding a bunch of supplements, vitamins, improve your outcome? And the answer is no. The one that may have the biggest benefit, particularly in stroke, is folate. We've talked a lot about methylation, folic acid. You can also just eat foliage, is where folate comes from. Green things, which would also reduce your risk of stroke. No benefit in the quite large meta-analysis of most of the supplements in longevity of life, and there is a potential for harm. There's been 2 large meta-analyses now showing that excessive calcium may increase all-cause mortality from cancer and increase the incidence of stroke. Remember, just taking more of a good thing is not always a good thing. If I take a lot of calcium, what does that do to my vitamin D levels? Suppresses it. The body's in this intimate balance. And just giving more stuff actually can cause harm, and mortality rates have been found to be higher in those who take a multivitamin versus those who don't. All right, and lastly, let's just review which drugs deplete which nutrients. If you look in the metformin package insert, it recommends checking B12 every 3 months. We generally don't do that, at least in primary care, but it shows how important this is in depleting B vitamins. And boy, we give out metformin like candy. ACE inhibitors. I like to teach the residents ACE to zinc. If you have a little old person who's on ACE inhibitor and they're getting recurring infections, or their mood, as Bob taught us, might be depleted, check their zinc level. It's a really easy thing to do. It's a rather cheap test to do, and supplement them or change them off their ACE inhibitor if their zinc level is low. Acetaminophen depletes glutathione. There was a study of pregnant women who took acetaminophen, and the offspring had a higher rate of behavioral problems, attention deficit, autism spectrum. And one of the hypotheses was that acetaminophen depleted glutathione levels, which is the most important antioxidant created in the liver. Proton pump inhibitors pretty much deplete everything because we need acid to absorb key nutrients such as iron, magnesium, calcium, zinc. Insulin. This one is an important one for how many people are on insulin, depletes magnesium. And lastly, this was mixed in the literature whether coenzyme Q10 really made a difference on people with statins. A meta-analysis published this last year showed that it does. It does help reduce myositis and fatigue of the muscles. All right, right on time. Who's next? Bob.
Oh, deja vu. Okay. All right. There we go. All right, let me go back, actually. Close your computers, please. People at home, don't close the computer because then you're gone. Just look at the screen, the full screen, the present slide, okay? Everybody's closed. I see a computer open over there. Okay, so here's what I want you to do. Get a piece of paper and a pencil or pen. I'm going to give you 30 seconds to do this problem. This is not moving. There we go. And I also don't have the timer on. Okay. Connect all 9 dots with a straight line, 4 straight lines without lifting your pen from the paper. Okay, connect all 9 dots, 4 straight lines without lifting your pen from the paper. Okay, I think some of you, about 20% of you, I see the pen going in all directions, so you're obviously frustrated. That's the point. Okay, so here's the solution. Now you go outside of the box. Bingo. What happened? Your brain said, this is a box. I have to do this in the box. This is an automatic assumption. We live with automatic assumptions. This is part of the foundation of cognitive behavioral therapy for mood disorders. But I'm going to talk about something in the context of depression. I want to talk about some of our fundamental automatic assumptions. So first we talked earlier about learned helplessness. I said you got to figure out what's the electric shock. What is keeping your patient in the box, right? Is it reality-based? Maybe it's a real situation. Maybe it's not. Maybe it's cognitions that are impaired. Maybe they're fortune-telling or catastrophizing or making all kinds of automatic assumptions. Maybe it's their basic schema about life. Like, I can't function in life unless someone takes care of me. Or I can't function in life unless I have control. or whatever it is. So that's learned helplessness. And the idea behind learned helplessness, the automatic assumption behind learned helplessness, is that the locus of control should be within us, right? How many people like to have control? If you don't raise your hand, I know you're a liar. So, we love it. But really, is the locus of control inside of you? Really? Like, just think about this. How did you get here? What was required for you to get here? You made a decision, you made a choice, right? You made a choice. The people who are on live stream, maybe they didn't have the choice to come here. Maybe they had to take care of kids or whatever. They didn't have a choice, so they have a choice of attitude. How are they going to take this? Are they going to be upset that they can't be here, or are they going to enjoy what they're doing? Hopefully they're enjoying what they're doing. But how did you get here? You drove, you flew, maybe you walked, but if you drove or you flew, you had to be in an airplane. That metal had to be mined by miners. Those mining machines had to be built with metal that had to be mined. You owe it to the person who invented the wheel millions or thousands of years ago that you were able to get here, right? The gasoline, right? The stewardess, the fabric. I'm just talking about the plane, the cab driver, the Uber, the people that wrote the software for the Uber. How did you get here? Was it you? You made a choice, but you were on a wave. You were on a wave through the environment that you're in, and you were able to ride the wave here. You made the choice, but you didn't exactly make it happen. You took one foot in front of the other. So really, is the locus of control really inside? Not really. We love it. It's a wonderful illusion, but it is not true. What's true? What's true is that we are part of a vast matrix. How do we know there's more going on? Well, the electromagnetic spectrum, we see light, we see colors, but we know that the electromagnetic spectrum extends out both directions. The physicists tell us that 95% of the universe is dark matter and dark energy, right? 95%, and they don't know anything about it. The 5% of the material universe, we don't even know anything about that. So what do we know? We know that 80% of what we teach today is false. So what do we really know, right? We are part of this great matrix. We live in the illusion of control, in the illusion of separateness, but consciousness, which you experience as local, you have your consciousness. Your consciousness is actually non-local, right? I'm affecting your brains. You're affecting my brain. We have this global field of consciousness. We have this consciousness that extends around the planet, okay? We are cut off from that. The guy who did the frontal lobotomy, I think it was Moniz, he won the Nobel Prize because he said, well, the prefrontal cortex, no function. Let's just stick a knife through here, a little probe, and separate the prefrontal cortex from the rest of the brain so that people don't have severe intractable OCD. He won the Nobel Prize. Well, there's no function to the prefrontal cortex. Of course we know there is. The appendix, of course there's a function. Junk DNA, of course there's a function. Dark matter, of course there's a function. Dark energy, there is a function. So we are in what I think of as, we have a metaphysical lobotomy. We are cut off from the idea that there is something beyond our physical world that influences us. We just don't accept that because we are in our scientific mind. That's a big mistake. And that's a big mistake for patients who want to have resilience against depression. Big mistake. So part of what I'm saying is that you have to open up the consciousness of your patients. It's very hard when someone's depressed to talk to them about this. They're going to be like, I got to find another doctor, you know. But when they get better, when they're ready, you know, it's important. So, all right, so that's that. So now, We all are on the same page. We all acknowledge now there's a hell of a lot going on. We don't know. And we have a metaphysical lobotomy. Okay. I now want to say that we're all brainwashed. Now, who's not brainwashed here? Okay, who is brainwashed? Yeah, we're all brainwashed, right? You see an event here and have someone from another culture see the same event, different take, right? What are your cultural biases? How is your brain being shaped by the environment that you're in? It's totally shaped. My brain is shaped by being a psychiatrist. It's warped, you know? It's totally warped. So when I realized this, that we are really brainwashed, literally, I was like, wow, it's kind of interesting because maybe I need to choose how I'm brainwashed. Maybe I need to choose what washing machine I stick my brain into. So what I did, I was raised in a Orthodox Jewish family. When I actually became a teenager, I discarded it, went off to college, learned, had a great biology teacher, was totally convinced that there's no need to postulate the presence of a God or a creator or anything like that. It's like, you know, it's obvious. You have the Big Bang, then you have all this whole sequence of steps and everything, so forget the God thing. So I didn't say to myself, well, where did the Big Bang come from? I didn't say that. So I kind of really adopted the idea of spontaneous generation. Right? Remember that germ theory? Where do germs come from? Spontaneous generation. So do you believe spontaneous generation of the universe? For me, it's hard to swallow. So what I decided to do was to look at different religious approaches, different philosophies, everything. I went to a universalist church, I went to Buddhist things, I did the meditation, the TM. I was just looking, I thought, you know, I was raised this way, then my professor raised me that way. Now I'm going to figure out, what do I think? So I actually spent 10 years and just trying to figure out, A, do I think God exists? You know, and I say God, not the guy with the white beard, okay? I'm the guy with the white beard. Now I say God, whatever you want to, the great as if, the thing you can't describe. Forget what you were raised with concepts of God. Think about it as this trans-universal whatever. So I did and I said, you know, I can't prove the existence. I can't prove the non-existence of God. So the only logical position is agnosticism. So then I'm left with faith, maybe. Maybe I could be agnostic, or I could say, no, I'm atheist, and I have faith that there is no God. Or I could have faith that there is a God. Now, the data seems to indicate that having faith that there is a God is actually beneficial to me and to the people I'm around. So my logic says I should probably brainwash myself. I'm serious. It's like, okay, this is going to be a trip. Now I got to do this. So eventually really found myself going back to a particular type of Judaism and knew that I had to brainwash myself, but then my logic would not take me where I wanted to go, but I couldn't cross that bridge, you know? One day I was walking through in my office. I have these huge charts, the Roche lab charts of all the, I think David showed it, of all the chemical reactions in the body. So there are two huge charts. I blew them up and I have them in my office. One day I'm walking by and I was like, oh, this is an accident, right? Okay, I succumbed, but it was success for me. Still, my logic didn't let up, okay? I struggle and struggle and struggle and have come to a point after years of comfort with this idea that there is some kind of force or entity or intelligence that I can actually relate to and that actually has an influence in my life. Call me psychotic. I don't care. So What if I said to you there's a new treatment that prevents depression, decreases the incidence of depression by 29%, reduces all-cause mortality, gives you 7 extra years on your life, suicide rate reduced by 84%, reduced rate of divorce, right? Decreased substance abuse, increased happiness. Do you want it? Okay, what is it? It's religious affiliation. Okay, so for some of us, that's a hard pill to swallow. We have bad experiences. There's some bad stuff being done. You know, not all of these organizations are very mature. You know, you need a mature organization that embraces cooperation, embraces life values, life-sustaining values. But here's a powerful tool. The logic to me says, maybe since I'm brainwashed anyway, I might have to brainwash myself in a way that I can take advantage of this. And I might want my patients to also, if they're inclined, take advantage of this. Maybe not. I'm not going to push it. Maybe they'd rather be in a yoga community. But it needs to be a community, a cohesive community. It needs to be affiliation. And it needs to have a spiritual, and I'm going to say metaphysical orientation. And with that, I think, over time, this is preventative. This is not when you get ill, it's a little too late. This is preventative. I actually wrote a chapter about this in the textbook of functional medicine. And the data is pretty clear. This is preventative medicine. So I want you, my goal here is to have you open your mind, because on the East Coast, where I am, the West Coast maybe, this is not PC. This is hard for me to tell people, certainly in this audience. I'm actually stepping out of the box, my zone of comfort, and talking to you about this, because I'm imagining that some people are going, oh man, wow. See, I got this little cap on my head, right? That's part of my brainwashing. Why? Because it reminds me that there's something greater than me that I don't understand. And I want to remember that all day long as much as possible. So that is the lens that helps me protect myself against leaky psyche syndrome. That's it.
Wow, I have chills after that one. Okay, so I'm going to speak to you today and share with you about social genomics. And sociogenomics is a topic near and dear to my heart because it's strongly related, the influences of it are strongly related to how we can impact our patients with pain in particular, all of our patients, but specifically I want to influence your thoughts around or give you ideas around how this is going to impact your pain patients. What's so interesting is that, you know, the things that we think about as our highest possibilities for mortality, physical inactivity, alcohol use, smoking, are actually less impactful on our mortality rates than social stress. I'm going to repeat that, because it's actually very important for us to really take that in and help communicate that to our patients. It's the high social stress that gives us the highest risk of mortality. Wow. This is not something new in the research. In fact, we've seen in the past, and some of these slides, I want to thank Monique for putting these together because this was part of a presentation she had given previously, so thank you for those. In terms of looking at the literature, we see that almost 20 years ago, that the integration of societies and the expansion of their capacity to interrelate and increase their individual social integration actually changed mortality rates. The work of sociogenomics has been really coming to the forefront, and part of what we see as being most important are the specifics around social isolation in regard to targeted rejection. And I think this is so prevalent now, especially with all the social media. Would you say not? I mean, it's huge. We see this in our adolescent population, but it's true even of our adult population. One of the questions that I've now added into my dialogue with my patients and in my intake with new patients is, how much time do you spend on social media and in what forms? And if they say, oh, I don't know, or they give me these estimates, I said, do you have a smartphone? Can we take a look? Would you be willing to look? Because, you can check that on your phone. And people are blown away by how much time they spend on social media. And I have one patient in particular who had high anxiety. And when we sorted out how much time she spent on social media, she realized it was a big driver of her anxiety. And she actually identified that she felt worse being on Facebook than she did not being there. We took a detox from her social media for a few days just to see how she would feel. I wanted her to experience and tell me what she experienced. It was highly impactful. So targeted social isolation can happen in many different forms. It could be you didn't get invited to something that you thought you would be. You were left out of a project that you thought you would be invited into at work. There's many different forms. But also, I want to submit to you the possibility of the internal dialogue that happens in our pain patients because they are so stuck in the pain pattern. And the internal dialogue is self-deprecating and a feed-forward cycle in their own internal dialogue about how they isolate themselves, how people don't want to be around them. They start to perceive themselves in many of the ways you heard Bob speak about, and the more they isolate themselves, the more they feel targeted. And then it can become a feed-forward cycle. So these social isolation studies are showing us that the genomic effect can affect up to 209 genes in our bodies, have varying effects, and turn on inflammation, turn on cortisol, turn on the stimulants that drive inflammatory-based disease, and decrease the genetic effects of those genes that would buffer those effects. So it's just profound what we see. Increase in FKB, you've heard a lot about that these last few days, and decreasing glucocorticoid receptor activities. So does the brain respond to physical and social pain the same way? What do you think? What do you think? Live streamers, what do you think? The answer is yes. Remember what we spoke about in that video in the very first pain talk? That pain, emotional pain and physical pain, are felt in the very same regions and expressed in the very same regions of the brain. And we see that here in this study. And that it can take us, 2 minutes, the time frame that they did in this study, looking at MRI and the reactivity of the brain to stimuli where people came in and had a particular exercise they were performing, and when things switched to the place where they felt they became isolated from the activity that was going on, it took 2 minutes. 2 minutes to turn on those genes that made them feel isolated, that because they felt isolated, that made the activity of the genome that triggered inflammatory processes. So think about that. And I want to submit to you, how much time are you spending on social media? I've been looking at that myself in my own life, and I don't even spend a lot of time there. But what is the feeling that you have when you're engaged in that? Does it make you feel energized and happy? Or do you feel more disconnected? Do you feel more connected or disconnected? And that's the piece I want to, really support you in starting to have dialogue with your patients. And find out, where do they feel most socially isolated? And why? And what's happening? Let's get down underneath that, because it's a big antecedent and a big trigger. So also the anticipation of isolation or rejection can be just as valid, and we see it in the studies. It turned on the same genes. It has the same effect. Just the anticipation of it, the thought that I won't be invited, or I will be left out, or my pain is so bad today, or my IBS is so out of control, I'm not going to be able to do my job or get to where I need to go. Whatever it is, right? The anticipatory aspect of the way in which we isolate around our diagnosis, around our story, or around the social aspects of isolation. But the great news is, there's good news. We can flip it in the other direction, because the work of, I believe this is Burke, yes, is that there's a buffering effect when we anticipate joy. So anticipatory joy, and the work that Burke did was just looking at the effect of knowing you were going to, or anticipating that you were going to watch a funny movie. I mean, that's pretty basic, right? So you're going to watch a funny movie, that you're going to experience yourself laughing and be happy. Turned on the same genes of down-regulating inflammation, of NF-kappa B down-regulation, of IL markers that decreased inflammation. So what are the ways in which your patients are anticipating joy? I have my patients write a joy journal, and I start with just one thing. What would bring you joy? I ask that question in every visit. We check back in around it, and if it's not ongoing, we anticipate it until it becomes live. And we see increase in beta endorphins, human growth hormone. We see decrease in cortisol by up to 39%, epinephrine reduced by 70% just by anticipating joy. This is a huge tool in our toolbox, is it not? So this communication that we've been talking about, this therapeutic encounter that we've been speaking of, this energetic connection between each other, one another, and between us and our patients is very real. And being able to ground ourselves and center ourselves and gather ourselves first, as Dave was saying, Dr. Rakel, that we must care for ourselves to be able to be effective in this work and be looking at how that also affects our patients. So again, meditation, 12 minutes a day for 8 weeks, and caregivers of dementia patients decreased 68 NF-kappa B associated pro-inflammatory genes. Wow. That's a powerful anti-inflammatory. And 8 weeks of mindfulness-based stress reduction program in healthy older adults, decreasing 143 NF-kappa B associated pro-inflammatory genes. It's real. This effect is real. We're seeing it repeatedly in the literature. And the work of HeartMath, again, is another way in which the science is very strong and a really great starting point for all of us, or being able to find HeartMath practitioners in our community that we can collaborate with. If it's not something you want to actually do in your practice, there are a lot of HeartMath practitioners out there. So I invite you to collaborate, because our heart field does affect our social environment. And I want to take you briefly through a case that I think is such a great example of what we've been talking about this weekend, as well as what we're talking about now. This is Jan, a very dear patient of mine, 74-year-old woman, extreme fatigue. She is the mother of a patient of mine. And the family came to me and said, we have problems, we need your help, can you help us with this? She'd been completely worked up medically before I'd seen her, and was in a state of extreme fatigue, extreme depression, fibromyalgia, lots of pain, heaviness, fatigue, couldn't really move much, increasing cognitive decline, really starting to have rapid memory loss. So she had gone through some very big triggers, caretaking for her parents who were dying. It took her away from home. She would travel to care for them. She was completely out of her support system while she was doing this. Her parents both died within 12 months. And then her beloved dog, those were her words, my beloved dog, died shortly thereafter. Rapid decline, significant fatigue, musculoskeletal pain, depression. This is after these events occurred for her. Moved straight into depression with rapid memory loss, loss of appetite, very much accelerated fatigue to the point of being bedridden. She had been given antidepressants. As I mentioned, she had multiple medical workups, and they had also identified some folate metabolism issues and had given additional folate, which helped a bit with her antidepressive meds, but not that much in terms of her overall quality of life. Nutraceutical support, she was on adrenal support, she was on nutrients for fibromyalgia type support, malic acid and a few other things, mostly adrenal herbs when I had seen her, and was told she had adrenal fatigue. So we went ahead and did a workup for her and really identified through all the mechanisms we talked about that she had significant micro and macronutritional deficiencies. Of course, she was barely eating at the time I met her. She had zero interest in food, very low appetite, and high oxidative stress, impaired mitochondrial function, sarcopenia. She's laying in bed, not moving, muscle wasting, significant dysbiosis, gram-negative bacteria, LPS activity, severe grief. I mean, she had the gamut. The ink was packed on her matrix. Her words, "I feel disconnected from my spiritual life." Thank you, Bob. Because this was something that she identified. She had a very strong spiritual practice prior to all of this happening for her, and then it just flipped the switch for her. She said, "I can't remember my life, Dr. Perry. I can't remember my life." So, how are we going to get this patient back on track? How are we going to help her reconnect to herself, to her family, to her life? We're going to bring the help to her. So I just figured, all right, we can't, she's already been out to all these other doctors. What are we going to do? We're going to bring the help to her. We're going to cast that net that I've been speaking of. And what we did was we engaged her community. We engaged her healthcare from the outside in. Mito Food Plan, we got a neighbor across the street who had a daughter who was actually studying nutrition to come in, shop for her, prepare the food, and make meals. 5R GR repair, we worked on that. We had family members and coaches of neighbor friends and family friends come in and support and help her. We applied kinetic energy and boosted her mitochondria through food. We actually coordinated having acupuncture come into her home twice a month and craniosacral come into her home initially twice a month. Exercise, we started very slow and low. At first, she couldn't even get out of bed, so we just did motion and movement in bed. And I gave her very specific movements to do. Daily, I asked her to at least be able to get herself, as soon as she could get out of bed, her face in the sun, her body in a window, somewhere where she could see nature and connect. And we just took it one step at a time, but we asked her to start to connect to her outer community through email or phone calls or write a card or something, and just be in the space of connecting with others. Eventually, we got her to the point where she could work with her tablet and send emails and start to connect with her daughter and her grandchildren who were living outside of the home, which just really brought her back to life. So our goal was to really connect her to her joy, connect her to the meaning in her life, fuel her body with nutrition, and we weren't loading her with a lot of nutritional supplements because she couldn't tolerate a lot, but we did address things as noted before. Within 12 months, she was celebrating holidays with her families, her grandchildren, and her family unit. 18 months, she's out of the house walking 3 to 4 times a week, having interactions that bring her joy. Daily movement, 20 minutes of walking 3 times a day now. She says, these are her words, "I do not miss." Mitochondrial food plan. And I asked her, she said to me, "Dr. Perry, if there's anything that any of your patients who ever need to know my story and that will help them, please use my words." Here they are. Sometimes we're taken to places we didn't expect to go to get to the places we need or want to be. Every step forward matters. Every step. Never give up, even when you feel like giving up. Our heart field matters. What we extend into our heart extends into our communities, extends globally, extends to all of you in live streaming. And it's possible to take the most difficult patients with pain and fatigue and move them forward. Just stay creative and stay curious. Thank you.
Exercise and movement, mood, movement, and mitochondria. The neurochemical and neurometabolic changes that happen when people move or exercise, I prefer the word movement, are profound. Not to be underestimated, not to be missed. And the changes can happen with certain forms of exercises within 4 minutes. So movement versus exercise. The opposite of sedentary is not exercise, it's simply moving the body. Have you guys heard this, sitting is the new smoking? Yeah, sitting is the new smoking. So the American Heart Association says that physical inactivity is the 4th leading cause of death worldwide. The 4th. Why is it bad to be sedentary? This is an interesting study. Every hour spent sitting watching TV takes 22 minutes off of your life. 22 minutes off of your life. So live streamers and everybody out there, if you're in a bad marriage, maybe a clicker for an anniversary gift, maybe a good idea. Just kidding. Just kidding. Something to consider. Large Canadian study found that people who were inactive had a 50% more were 50% more likely to die by the next doctor's visit. So what does movement and exercise do for the brain and for cognition? So aerobic training and cognition. This is aerobic training 3 times a week for 60 minutes, improve vascular cognitive impairment in older adults. 3 times a week, 60 minutes, and all they did was walking. Moderate, continuous exercise with friends in a group. So they didn't control for that variable, but I think that's a very important variable to look at. But it was walking, 10 minutes of stretching, and Lisa commented on this during her talks. Really important to stretch before and after you exercise. 10 minutes of stretching, and then 40 minutes of walking. The neurochemical changes that happen with acute exercise are profound. So what we mean by acute exercise is you don't have to work up to this. It's one bout of exercise has these neurochemical changes. Increases brain-derived neurotrophic factor, increases dopamine, increases serotonin, increases GABA, increases the endocannabinoid, it trips the endocannabinoid system, especially if you're doing, and we're going to talk about this, high-intensity interval training. This is a complicated slide, but I'm going to give you the big takeaways, if I can look at this. Someone who is at low risk for cognitive decline, this is the line right here, the peach line, and they exercise throughout their lifetime, through childhood. There's only a dip in cognition and structure and function of the brain in the last decade, and that dip is small. If these same people become inactive in their 20s and 30s, this is the dip in structure and function that happens. Now here's the good news. If they decide that they want to start exercising when they're 40, they can get a bump up. These are people at high risk. People at high risk early on in childhood. If they exercise and maintain it, they maintain structure and function the same way somebody at low risk does. Again, if they become inactive, look what happens. Major decline. If in their 30s or 40s or 50s they start exercising, they boost back up again. So the takeaways are, start people early moving and exercising, maintain it throughout a lifetime, but it's never too late to get a glove and get in the game and start moving and get these benefits. So does it improve cognition with Alzheimer's disease? And the studies really say if you catch it early, and it doesn't have to be much exercise, and different types of exercise will stimulate BDNF in different parts of the brain, but it actually slows down progression and in some instances actually improves even with moderate to severe Alzheimer's disease. So you can look here, and again, like I said before, depending on what type, whether you're doing aerobic exercise, resistance training, balance training, like sitting on a ball or doing yoga, you're going to be stimulating different parts of the brain. That's why it's good to have diversity with exercise so that you get all areas of the brain. So you want to do something that involves balance, even if it's sitting in your office on one of those big balls and you're going to be working on balance. You want to do something with strength, and you want to do some type of aerobic activity. Exercise and depression. Bob was talking about this, but exercise is as effective as any known treatment for depression. This is a study that was done twice a week, 45 minutes of weights to music for medication-resistant depression, and there was a decline in depression by 30% over the control group. That is profound, just moving the body twice a week for 45 minutes. All exercise across the board, no matter what you do, enhances mitochondria biogenesis. That's the creation of new mitochondria. And it's systemic. Meaning, when you exercise, it increases mitochondrial biogenesis in the liver, in adipose tissue, in the brain, in the kidney. It's a treatment that helps globally. So, does the intensity of exercise matter? Live streamers, what do you think? Audience, what do you think? Do you think intensity matters? Intensity does matter. So let's talk about the different types of intensity. But I want to say this right up front. Just get people moving first, and then you can split hairs over the subtleties. But this is the subtleties. So light exercise is like you're going out walking your dog, and you're stopping and you're going, and you're stopping and you're going, and you're not sweating unless it's humid out. It's 40 to 55% of your maximum heart rate. And you can figure it out by physical cues, by just, you can talk, you're walking, you can sing, you're having conversations, you're doing light exercise. Then there's moderate intensity. You're going to sweat after 10 minutes. You can breathe, you can carry on a conversation, but you can't sing. Then there's high intensity interval training where you can't carry on a conversation, you can't sing, you may be able to say a small word, you're going to sweat after 3 to 4 minutes. And this is like the Tabata method where you're going to whatever your full capacity is for 20 seconds. It's high intensity, low impact. Then you have a 10-second break where your heart goes back down, so there's a real heart rate variability or flexibility happening. And then you go back for 20 seconds doing something very intense. So that's high intensity interval training. The key is with all of these things, you've got to be breathing. So even with high intensity interval training, if you cannot breathe, you shouldn't be able to talk, but you should be able to breathe, you're doing it wrong. And it's actually working in the negative column. Because what do you need? David said this the very first day. You need oxygen for oxidative phosphorylation to produce ATP. So key is people need to be breathing with high intensity interval training. So it's high intensity but low impact. The neurochemical changes happen after 4 minutes. 4 minutes of 20 seconds to full capacity, and your full capacity is going to be different than your full capacity, is going to be different from your full capacity, is going to be different from your full capacity on live stream. So here's some of the science that opiates in high intensity interval training are more increased than moderate, low to moderate continuous exercise. So what that means is if you're running at a 15 minute per mile pace, at the same pace, you are not going to get the same opiates as if you did 20 seconds 10, 20 seconds 10 for 4 to 7 minutes. Interesting, right? Neuroplasticity, brain-derived neurotrophic factor increases significantly higher when you do high-intensity interval training, but low impact. High-intensity interval training is superior to lowering cardiometabolic risk factors compared to continuous moderate exercising, doing something at the same pace. There's something about the diversity of up and down, up and down, up and down. So high-intensity interval training, here's a chart just showing you, it increases growth hormone over light to moderate, opiates, nitric oxide goes up. They both improve insulin receptor sensitivity and immune-enhancing Treg cells, but high-intensity interval training does it more. The negative column, high-intensity interval training, there's more inflammation and oxidative stress when you do it. So if you've got people with complex chronic disease, you want to start them slow. If they cannot do the same exercise the next day, maybe you start them with a minute of HIIT or 2 minutes of HIIT. If they can't do it the next day, you've overtrained them. If they're fatigued the rest of the day and they've crashed, you've done too much. So you want to do this in the morning because people that have a decrease in motivation, that's a decrease in dopamine to the frontal lobe. One of the best things you can do, even if they want to go for a 4-mile walk later in the afternoon, is do 4 minutes of HIIT to their capacity. So that can be jumping jacks, that can be running in place, that can be a plank, that can be stepping up and down, whatever works for them. 4 minutes in the morning, you're going to get that dopamine to the frontal lobe. And then if they want to walk, they can do it later. But just remember, when you do HIIT, there's an increase in inflammation and oxidative stress. So there's a benefit up until a particular point. And then there's a loss in benefit if you go over and create too much inflammation and oxidative stress. And there's going to be a back and forth with this. So there's no way to figure this out because it's so personalized that each individual has to figure out where their threshold is. So how much exercise should people do? Everybody has different recommendations, but when you're looking for cognition, 1 to 5 hours a week of moderate continuous, like walking or a slow jog. Some people say 45 minutes, 3 to 5 times a week of aerobics. HIIT, you don't need to go over 20 minutes for high intensity interval training. And I encourage people with complex chronic disease to start with 1 or 2 minutes, build up, knowing that the benefit starts at 4. And even if you stop them at 7, they get full boat at 7 minutes. So work slowly. So personalize these things. Something you guys don't know about me, 2 things, is that I typically run late. And I'm always running late to my yoga class. So this is my yoga instructor was trying to reroute me and create neuroplasticity and new neuronal networks. So I would be on time forever and it wasn't working. And one day I walk in and she had gotten this t-shirt and she was standing there smiling instead of being angry at me. And the t-shirt says, "Does running late count as exercise?" So personalizing and facilitating change, making movement a habit, it's got to be fun. Whatever people are doing, it's got to be fun. If it's not fun, they're not going to continue. Start slow so people have success and build. Movement begets movement, begets movement, begets movement. It's about momentum. Life is about momentum. Exercise is absolutely about momentum. If you're sore, if you're sore or too fatigued to do things the rest of the day, you've overtrained, slow it down. Make sure you're breathing. You need oxygen for oxidative phosphorylation. Try to get walking partners and exercise partners or yoga classes. My people in my yoga class, they know all kinds of things about me that some of my closest friends don't know because they see me so many different days during the week on a daily basis. And do high intensity but low impact. Track your progress. So, key things. Move to your capacity, make sure you're breathing, and think low impact but high intensity. With that, I want everybody to stand. You guys didn't know this about me, but I am a high intensity Pilates instructor when I'm not lecturing for IFM. So you guys are going to experience your 4 minutes of HIIT. Okay, Trevor, you got it? Make it louder, Trevor. Do whatever you want, guys. Let's go.
Sugar.
To your capacity, make sure you're breathing.
Honey, honey.
10 more seconds.
My candy girl.
All right. Woo!
You got me wanting you.
And break.
Oh, sugar, sugar. You are my candy girl. And you got me
go.
wanting you.
Make sure you're breathing.
I just can't believe the loveliness of loving you. I just can't believe it's true. I just can't believe the wonder of this feeling too.
And break.
It's true. Ah, sugar.
Live streamers, I'm watching you.
You are my
And go.
girl, and you got me wanting you. Oh, honey.
Make sure you're breathing.
Oh, sugar, sugar. You are my candy girl,
And break.
wanting you.
Catch your breath.
When I kissed you, girl, I knew how sweet a kiss could be.
And go.
Like the summer sunshine.
Nice job.
It's over me. Boy, your sweetness over me.